adult ophthalmology is too big of a topic to cover in one video. So what we've done is chosen select topics that tend to show up on the test. Let's go through them all one at a time, starting with closed angle or narrow angle glaucoma. This gets to be pretty complicated as you explain the anatomy of the eye, and you just don't have to have that profound understanding of anatomy of the eye for the test. So I'm going to try to stay away from it as best I can as we explain this disease. What I want you to realize is that this disease is caused by pressure after dilation. And basically, it's that when the pupil dilates, fluid can't leave the posterior chamber, and so pressure develops as the fluid begins to swell. The patient presentation is almost always going to be the same. The person enters some low light situation, like watching a movie that causes the pupils to dilate. They go into a movie theater or they go see a play, the lights are low, your pupil dilates. When the pupil dilates, flow out of the chamber decreases. This causes increased pressure. And that pressure is going to give you the symptoms. The eye pain, the headaches, and the physical exam maneuver, you're actually going to have a rigid eyeball. That increased pressure also worsens the condition because now the pupil cannot constrict, so you're going to have a dilated pupil that's non-reactive. And since it's dilated, it's going to decrease the flow out even more. So the eye is going to be painful, red, it hurts, there's a headache, and the eyeball is rigid. And that's how you make the diagnosis. It's clinical. You measure the ocular pressures. And if the pressures are elevated, this is an acute attack. You need to get the pressure undone and the pupil constricted. So constrict the pupil, relieve the pressure. This is a medical emergency, so to relieve the pressure, you're going to use a laser and literally drill a hole in the eyeball, relieving the pressure. And then to constrict the pupil, and I don't remember alpha, beta in the eye. I just remember the therapy for this, and I go from there. I know I want to constrict the pupil, and then I use the mnemonic, activate alpha, block beta. You want to give alpha, activate alpha, block beta. Activate alpha, block beta. Alpha agonists and beta blockers as drops on the eye to constrict the pupil to undo the pathology. And never give atropine to these patients ever. Atropine will precipitate an acute crisis. That's the one you got to know the most about. The rest of these get a little easier. Periorbital cellulitis is a big deal because if you've got an infection of the skin around the orbit, no big deal, it's a cellulitis. But if you've got an orbital cellulitis, that could cause a loss of vision and needs to be intervened on surgically. So you're going to see some sort of inflammation around the eye. There's going to be some sort of inflammation in the eye region. And they can show you a really nasty looking eye, right? There could be just this big pus collection. The eye could be swollen shut. It could be tearing. It doesn't actually matter because what you want to ask is, are the extraocular muscles intact? That is, can they move their eye? If yes, it's a periorbital cellulitis, and all they need is antibiotics. Because the way you're going to diagnose orbital cellulitis is to rule out an abscess or some infection that came from the sinuses or deeper in the skull. So what you're going to have to do is get a CT scan. And if you find something, because it's usually an abscess, you're going to have to drain it, do surgery, and give antibiotics. That's in the case where they cannot move their eye. And in the case where you have a diabetic, especially in DKA, presenting with this disease, consider mucormycosis, which needs amphotericin. Otherwise, you're just covering for the typical skin flora that cause cellulitis. Corneal abrasions, really easy to spot, especially on the test. It's going to be somebody who's doing something where they're supposed to wear goggles and they don't. Corneal abrasions are caused by something getting into the eye, and it scratches the cornea. So the person's going to be doing some sort of hobby or job where they should have goggles, but they're not. This is going to be things like chopping wood, working with metal, firing guns. They're supposed to be wearing goggles, but they don't wear the goggles, and all of a sudden their eye hurts, it's red, and it's tearing. If you see this, well, you want to make sure you get that thing out of their eye. So you skip right to treatment, which is irrigate. And you irrigate a lot. You constantly irrigate, you constantly flush until you get all that stuff out. After that, you want to know how bad the damage is, and if there's an infection or an abscess thing you set up, the diagnosis can be made with a fluorescein dye. And you'll actually see the abrasions, the scratches in the cornea. And if they're bad enough, you might need to do surgery, but generally surgery is not required to manage an abrasion. You just flush it out and the cornea heals. Next up is retinal detachment. It's caused by one of two things. It's either going to be major trauma, as in a motor vehicle accident, or a hypertensive crisis, where the increased blood pressure literally pops the retina off the back of the eye. And this is a cause of acute blindness, and if not fixed, it's going to be permanent. The patient's going to complain of floaters. And if they say floaters after hypertension or an MVA, this is mild disease. If they complain of a veil or a curtain coming over their vision, this is severe. The diagnosis is going to be made clinically. You just look in the back of their eye and you see, hey, the retina's not attached. And because it's not attached, you've got to reattach it. And the way you do that is by literally spot welding it with a laser. Now, if they say there's a curtain coming over my vision or there are floaters, but they come and go, it's not retinal detachment. So if the same symptoms comes and goes, the retina is not going to spot weld itself. It's not going to reattach itself if it's detached. It can't be retinal detachment. It is instead amaurosis fugax, which is a pending retinal artery occlusion. Now, there is also retinal vein occlusion, but I want you to learn retinal artery occlusion. And effectively, what this is an eye stroke. Amaurosis fugax is the TIA to retinal artery occlusion stroke. And I want you to learn it that way because it tells you what you need to do as treatment. Retinal artery occlusion is going to present as a painless, acute loss of vision that is unilateral. It must be unilateral unless you occlude both retinal arteries simultaneously. Unilateral, painless vision loss, but to separate that from a stroke of the occipital region, there will be no other focal neurologic deficits. And if you see on the test cherry red spots on the fovea, the diagnosis is done, retinal artery occlusion. Diagnosis is clinical, and the treatment comes down to treating the stroke. You're going to use intra-arterial TPA. There's some other things you can do to spare vision loss if you can't do intra-arterial TPA or to temporize to get them there. It's going to be things like hyperventilation and global pressure. You literally just push on the eyeball. What you're doing is trying to induce vasodilation, trying to push the clot a little bit further, so even if you can't do intra-arterial TPA, less vision is lost. We're almost done, getting to the end. Cataracts are next. Cataracts are caused by age and diabetes. What the person is going to complain of is a chronic progressive loss of vision. They also complained of difficulty with nighttime vision. And this is not hard to see, literally. You actually just look at the patient, and if you see that there's a white thing in the front of their eye, it's cataract. There actually is a white thing in the anterior chamber, which makes it a great question to just show you a picture of a cataract, and then you say, okay, that's a cataract. The diagnosis is clinical, and if it gets bad enough, you just go in there and remove the cataract. And lastly, we're talking about macular degeneration. When it comes to macular degeneration, you want to separate it into wet, which is about 20% of the cases, and dry, which is about 80%. The reason why you have to do that is because the diseases are actually very different. The way you see on the eye is different, and the way you treat it is different. They both cause the same problem, though. As the macula degenerates, what you're going to lose in a chronic progressive way is central vision. The peripheral vision will be intact, but the central vision is lost. And the problem with this is, if you've got the dry form, which is the more prevalent one, there is no treatment. So the way you diagnose it, the way you tell the difference, is by looking in the back of the eye. In the wet form, you're going to see some hemorrhages or fluid. In the dry form, you're going to see drusen or pigment changes. The treatment for wet is to use a laser. The treatment for dry is nothing. So this is a hodgepodge of ophthalmologic diseases that can affect an adult. Let's just run through them real quick to see what the highlights might be. For narrow angle or closed angle glaucoma, increased ocular pressures, what you want to do is relieve the pressure with a laser and constrict the pupil. Activate alpha, block beta. For orbital cellulitis, you look in their eye, and if they can move their eye, you treat them just like a periorbital cellulitis, which is like every other cellulitis with antibiotics. If they happen to not be able to move their eye, you're worried about orbital, do a CT scan and surgery. Don't forget about DKA and Mucor. Corneal abrasions, doing something where they're supposed to wear goggles but they don't, flush it. Retinal detachment is going to be floaters or a curtain after a trauma, do the laser. Retinal artery occlusion, painless unilateral loss of vision without any other focal neurologic deficits, intraarterial TPA. Cataracts, that white thing in front of their eye, cut it out. Macular degeneration, separate it into wet and dry, laser wet, nothing for dry. That's adult ophtho. Become a better doctor. Subscribe now to get access to our premium content.